Treatment for prostate cancer isn't one size fits all. It changes based on your risk level and how long you expect to live. Are you curious how doctors decide if surgery, radiation, or other therapies are right for you? Let's explore your options. Why does one man with prostate cancer get surgery, another gets radiation, and someone else gets only monitoring? The answer lies in the NCCN risk groups and your life expectancy. Today, I'll explain the treatment options for every risk group, from very low to very high risk, including surgery, radiation, hormone therapy, chemotherapy, and the latest advances. For men with very low risk prostate cancer, stage T1C tumor, grade group 1, PSA less than 10 nanogram per milliliter, cancer found in 1 to 2 biopsy cores with no more than half of each core showing cancer, PSA density less than 0.15 nanogram per milliliter, especially with a life expectancy above 10 years, the safest option is usually active surveillance. This means regular monitoring, not immediate treatment. PSA once or twice a year, digital rectal exam once a year, MRI every 1 to 2 years, prostate biopsy every 2 to 5 years. You won't receive any cancer treatment during active surveillance, but treatment will begin if your cancer grows or spreads. Secondly, if your life expectancy is less than 10 years, observation is suggested. Observation is for those who have other more serious health problems and whose slow growing prostate cancer isn't causing any symptoms. Observation involves occasional checkups with your care team, but no invasive tests or biopsies. Any symptoms that occur can be treated with palliative therapy. The low risk group includes patients who have all of the following traits: stage T1 to T2A tumor, grade group 1, PSA of less than 10 nanogram per milliliter, if life expectancy is 10 years or more, active surveillance preferred, or radiation therapy or prostate surgery is done. If life expectancy is less than 10 years, observation is preferred. The favorable intermediate risk group is for those who have only one of the following traits: stage T2B or T2C tumor, grade group 2, PSA 10 to 20 nanogram per milliliter. In addition to having one of these traits, another indication of having a favorable intermediate risk is that less than half of the biopsy cores removed during the biopsy show cancer. Treatment options for people with a favorable intermediate risk cancer are: if life expectancy is 10 years or more, then active surveillance, prostate and nodes removal surgery or radiotherapy. Active surveillance is not recommended for patients in the favorable intermediate risk group whose cancer cells are under the microscope, indicates a higher risk for aggressive or recurrent cancer. If life expectancy is 5 to 10 years, then observation is preferred over radiotherapy. The unfavorable intermediate risk group describes prostate cancer that has 2 or 3 of the following traits: stage T2B or T2C tumor, grade group 2 or 3, PSA 10 to 20 nanogram per milliliter, or at least one of these traits and more than half of the core samples from the biopsy show cancer. Treatment options for unfavorable intermediate risk prostate cancer is: if life expectancy is 10 years or more, prostate surgery with or without pelvic lymph node removal, or radiation therapy and hormone therapy, which includes androgen deprivation therapy combined. If life expectancy is 5 to 10 years, observation or radiation therapy and hormone therapy is preferred. The high-risk group includes people whose cancer has at least one of the following characteristics: stage T3 to T4 tumor, grade group 4 or 5, PSA more than 20 nanogram per milliliter. The very high risk group includes those whose cancer has at least two of these characteristics: stage T3 to T4 tumor, grade group 4 or 5, PSA more than 40 nanogram per milliliter. Treatment is more aggressive for high risk and very high risk prostate cancer. Treatment options are based on life expectancy and whether or not you have symptoms. If life expectancy is more than 5 years, then radiation therapy and hormone therapy like androgen deprivation therapy or radiation therapy plus hormone therapy and Zytiga, very high risk cancer only, is given for 2 years. If the life expectancy is 5 years or less, observation or radiation therapy plus hormone therapy or radiation therapy or hormone therapy or radiation therapy is given. When prostate cancer spreads to bones or lymph nodes outside the pelvis, we treat the whole body. Standard treatments include androgen deprivation therapy ADT, chemotherapy docetaxel, novel hormone therapies abiraterone, enzalutamide, apalutamide, PSMA targeted radioligand therapy, radiotherapy for bone pain. These treatments help control the cancer, improve symptoms, and prolong life. But treatment doesn't end here. Follow-up is equally important. Follow-up schedule for each risk group. After treatment, all groups. PSA every 6 to 12 months for first 5 years, then annually. MRI or imaging only if PSA rises. Continence and sexual function follow-up after surgery. Bone health checks for those on long-term hormone therapy. For metastatic cases, follow-up is more frequent, usually every 3 months. So how do we know if the treatment worked or if cancer returns? In the next episode, I'll explain a crucial topic: PSA persistence and PSA recurrence. What does it mean when PSA doesn't fall after treatment? And what if it rises again after months or years? These answers help us catch recurrence early and treat it before it spreads. I'm Dr. Shankar. Stay aware, stay strong, and remember, early knowledge saves lives.